Welcome to Pulse&Pressors, where critical care gets crystal clear. Today, we're exploring ketamine, a dissociative anesthetic with unique hemodynamic advantages in critically ill patients. Ketamine is a phencyclidine derivative that produces dissociative anesthesia. It blocks NMDA receptors, dampening excitatory neurotransmission and central sensitization, while preserving spontaneous respiration and sympathetic tone. Unlike most sedatives that drop blood pressure, ketamine often supports perfusion, making it a preferred choice when hypotension is a concern. Mechanistically, ketamine is a non-competitive NMDA antagonist. It also acts weakly on opioid receptors, monoaminergic pathways, muscarinic sites, and HCN1 channels. These secondary actions explain its analgesic, antidepressant, and bronchodilatory effects. The S enantiomer, or S-Ketamine, binds NMDA receptors about 3 times more strongly than the R form, producing greater analgesia at lower doses. Metabolism occurs in the liver via CYP2B6 and CYP3A4 to form Norketamine, an active metabolite roughly 1/3 as potent. Onset is rapid, 30 to 60 seconds V, 3 to 5 minutes IM, and around 10 minutes intranasally. Elimination half-life is roughly 2 to 3 hours, but redistribution explains why hypnosis is short while analgesia persists. Hemodynamically, ketamine behaves differently from propofol or benzodiazepines. It blocks norepinephrine reuptake and activates the locus coeruleus, causing an increase in heart rate, cardiac output, and systemic vascular resistance. Most patients see an increase in MAP. However, in catecholamine-depleted states, such as late septic shock or prolonged critical illness, this sympathetic stimulation may fail. In that setting, ketamine's intrinsic negative inotropy can unmask hypotension. Avoid large boluses, start low, and support with vasopressors if needed. It may mildly raise pulmonary vascular resistance, so use caution in severe right ventricular failure or advanced pulmonary hypertension. Neurologically, ketamine dissociates the thalamus from the limbic system, producing analgesia, amnesia, and sedation, while airway reflexes remain partially intact. Historically, it was thought to raise intracranial pressure. Modern data show that with controlled ventilation and normocapnia, it does not increase ICP and can actually support cerebral perfusion pressure by maintaining MAP. This makes it acceptable in traumatic brain injury when ventilation is well controlled. Respiratory effects are equally distinctive. Ketamine preserves spontaneous breathing and airway tone. It acts as a direct bronchodilator by releasing catecholamines and inhibiting calcium influx in airway smooth muscle. This makes it especially valuable in status asthmaticus and bronchospasm during intubation or ventilation. Let's review key ICU and emergency indications. For rapid sequence induction, 1 to 2 milligrams per kilogram intravenously, or half that if the patient is unstable. For ongoing analgesic sedation, a bolus of 0.05 to 0.3 milligrams per kilogram, followed by an infusion between 0.1 and 0.5 milligrams per kilogram per hour. In asthma, bolus 0.2 to 0.5, infusion up to 1 milligram per kilogram per hour. For refractory status epilepticus, bolus 1 to 3, infusion 1 to 5 milligrams per kilogram per hour under EEG monitoring. And for opioid tolerance or hyperalgesia, 0.1 to 0.3 milligrams per kilogram per hour as a continuous infusion. In ECMO patients, pharmacokinetics shift. Ketamine's lipophilicity causes adsorption to circuit tubing and oxygenators, especially after circuit exchanges, which lowers plasma levels early on. Always reassess sedation depth within 30 minutes of a circuit change. In VV ECMO, ketamine helps maintain blood pressure and spontaneous drive. In VA ECMO, avoid large boluses in right ventricular dysfunction due to potential increases in pulmonary vascular resistance. Therapeutically, ketamine offers several advantages. It maintains perfusion when others depress it. It reduces opioid requirements and prevents central sensitization. It produces minimal respiratory depression, and in low doses may reduce delirium compared with benzodiazepines. Its anti-inflammatory and antidepressant properties are linked to glutamate modulation and BDNF signaling, relevant in long-term critical illness. Contraindications are relative. Absolute allergy is rare. Use caution in uncontrolled hypertension, aortic dissection, or ischemic heart disease, where surges in pressure can be harmful. Be cautious in psychotic disorders or severe hepatic impairment. In catecholamine-depleted shock, avoid large boluses and support circulation as needed. Adverse effects are predictable and manageable. Emergence reactions, vivid dreams or hallucinations, occur more in adults than children and can be mitigated with small doses of Versed or dexmedetomidine. Hypersalivation is common, especially after bolus dosing. It can be prevented with a small dose of glycopyrrolate, about 0.1 to 0.2 milligrams intravenously, or, if unavailable, atropine, though glycopyrrolate is preferred because it avoids central effects. Nausea occurs in roughly 10 to 20%. Treat with ondansetron. Laryngospasm is rare but possible during airway stimulation. Manage with positive pressure and, if necessary, a short-acting paralytic. Monitor liver function with prolonged infusions. Mild transaminitis usually resolves on cessation. In pediatrics, ketamine remains one of the safest sedative analgesics. RSI dose, 1 to 2 milligrams per kilogram intravenous. Procedural sedation, 1 to 1.5 milligrams per kilogram intravenous, or 4 to 5 intramuscular. Intranasal dosing, 3 to 6 milligrams per kilogram when intravenous access is difficult. Continuous infusions typically range from 0.05 to 0.5 milligrams per kilogram per hour. In status asthmaticus, bolus 0.5 to 1 milligram per kilogram, followed by up to 1 milligram per kilogram per hour. Children are more prone to secretions and laryngospasm. Premedication with glycopyrrolate at 0.01 milligrams per kilogram, up to 0.2 milligrams total, helps mitigate this. Although rare in the ICU, urological toxicity can occur with long-term, high-dose exposure. Ketamine-induced cystitis presents with urgency, frequency, dysuria, and hematuria, typically with sterile puria. It results from urothelial inflammation and microvascular injury caused by ketamine metabolites. If prolonged infusions are required, obtain urinalysis every few days, maintain hydration, and discontinue ketamine if lower urinary tract symptoms appear. Most cases resolve once the drug is stopped. Monitoring during therapy should be structured and continuous. Use ECG and invasive blood pressure when indicated. Reassess hemodynamics within minutes of boluses. Apply capnography for all procedural sedations. In neurocritical patients, maintain normocapnia. After ECMO circuit changes, retitrate based on response. For long infusions, check liver enzymes and urinalysis every 48 to 72 hours. Ketamine interacts favorably with other agents. The combination of ketamine and propofol, known as ketofol, stabilizes hemodynamics while lowering total propofol requirements. With dexmedetomidine, ketamine provides cooperative sedation and suppresses emergence reactions. With opioids, it enhances analgesia and reduces tolerance. Reserve benzodiazepines for short-term use or emergence control. For prolonged use, simple monitoring bundles are effective. Check LFTs and urinalysis every few days, review sedation depth daily, and taper the infusion as the patient stabilizes. This minimizes rare toxicities while preserving ketamine's benefits. In summary, ketamine maintains perfusion while providing deep, titratable sedation and analgesia. It's safe in traumatic brain injury when ventilation is controlled, serves as a bronchodilator in asthma, and is invaluable in shock, ECMO, and opioid-tolerant patients. Emergence reactions, hypersalivation, and rare cystitis are preventable or reversible with basic precautions. For critically ill adults and children alike, ketamine remains one of the most hemodynamically stable sedatives available. This is Pulse&Pressors, providing a daily education on the marvels of the human body. Subscribe to stay sharp.